Aloha mai kako, everyone. We'll just give a few seconds to let everyone slowly trickle in. Welcome to tonight's Rainbow Town Hall. Okay, let's get started. Welcome, my name is Ian Tapu. I'm a board of director with the Hawaii LGBT Legacy Foundation, and I would like to welcome everyone to our fourth Rainbow Town Hall and what is a series of events, not just throughout the month of October, which is Honolulu Pride, but as part of the Legacy Foundation's larger movement to ensure that we continue to support and uplift our queer community 365 days a year. So tonight, I would like to pass on the torch to Danielle, who's going to be introducing our panelists and starting us off. Mahalo, Danielle.
Mahalo Tapu, and thank you to the entire Legacy Foundation for partnering with us at JABSOM to put on this event. My name is Danielle Sato. I go by she, her pronouns, and as well as being a part of the Town Hall series, this is also a part of our Partnership for Social Justice Interest Groups annual symposium. So really excited to see all the different kinds of people that are going to be attending tonight. Then we're going to start with just some quick introductions of all the panelists and my co-moderator Clark in the room. So just your name, your pronouns, what you do, and maybe what makes you passionate about this subject area. So I'll pass it to Clark first.
Okay, thank you, Danielle. Yeah, it's a pleasure to meet everyone, and thank you all for coming tonight. My name is Clark. I'm a third-year medical student. I go by he, him, and the reason why I'm interested in this subject is because I'm a part of the LGBTQ community myself, and I think that this is a really important subject to kind of know for the general population. So thank you all, and I'll go ahead and send this over to our panelists if anyone wants to go first.
Hey there, hi everybody. I'm Scott Denny. I use he, him pronouns. I am the medical director for our gender health services and medical director for HIV services at Kaiser Permanente, Hawaii. We call our clinic the Care Pathway Center. I am the immediate past president for the Hawaii Academy of Physician Assistants. And really for me, aside from just really being passionate about taking care of these patient populations, for me, injustice makes me crazy in general. So any type of inequity just gets under my skin. And for so long, LGBTQ folks have been really marginalized, and I think we need to really address these health disparities and figure out better ways to do that and to enrich our training programs and education programs, and just really appreciate you all coming together for this, and it's really exciting. Thank you.
So I can go next then. Hi everyone, Thaddeus Pham, he, him. I'm with the Hawaii Department of Health. I'm the viral hepatitis prevention coordinator in our harm reduction services branch, which is a mouthful. People in the community just call me Queen of Hepatitis, and I also respond to your majesty, so that's fine as well. To answer your question about why I'm interested in this work, well, like Clark, I'm part of the community, and like Scott said, injustice is just something that I can't abide by. And I think increasingly in this world, as we see more and more, everything is related to everything else. So intersectionally, we know that the work on equity for LGBTQ plus people is also the work for equity for other communities as well. So very excited to be here with my co-panelists to talk about more about justice and things today. So thanks.
Aloha, I guess I'll go next. I'm Dee-Ann Carpenter. I'm an associate professor at the Johnny Burns School of Medicine in the Department of Native Hawaiian Health and the Office of Medical Education. And I went to medical school many decades ago way more than you guys. And it was back in the late 80s. And so it was actually, you know, you become a doctor to help people. And that's when HIV came to be seen, and AIDS. And so I was actually part of that whole group and learning. And I was part of Student Educators Against AIDS. I was actually sharing with Danielle, I was the poster child with my colleague. If you had to go and when you were going to get married, you would see my profile to say, get an AIDS test, you know, get a test for HIV. So that was my claim to fame. Woohoo, pink poster back in the day. But mahalo for the Department of Health. So there you go. But, you know, so throughout, I've always wanted, you know, you care for people as people. I truly believe that. And like you, it's like, oh, injustice. What's wrong with people? I call it, we need slap therapy for some people. But anyway, we won't do that tonight. But basically, really want to, yeah. And I teach a little bit of cultural competence. That was so incompetent what I just said. But that was definitely the way I was raised. So with all of that, really, I just wanted to, you know, share my support and really kind of let you know, yes, I'm absolutely about tough love, and just, you know, share my support for everybody and see what we can do to really help the future providers that come out of our medical school. So wanted to talk to you about a little bit about what we do and what we can do. So mahalo for having me this evening. Aloha.
Aloha, everyone. I'm Camaron Miyamoto, he, him pronouns. I'm the director of the LGBTQ plus Center at the University of Hawaii at Mānoa. I'm honored to work for the students I do at the university. I'm honored to continue to learn from them every day. And I believe that change will come because of a steadfast commitment to education and social justice. That being said, I'm really excited about tonight's conversation because I feel like we're at a crisis point. Too many of us in the LGBTQ plus communities have been told things growing up or where we are now that we just don't matter. And it's at the point where taking care of ourselves and each other is revolutionary. So when we have the courage to take care of ourselves, seek assistance for a medical condition, I just want to make sure that we could have more and more conversations that we can bring our whole selves to that medical experience. So thank you.
That's wonderful. Thank you for sharing that. And I guess I forgot to introduce myself a little bit more, but I'm a MS2, so a second year medical student as well at JABSOM, and also part of the LGBTQ community and very passionate about how I can serve my community in the future as a physician and in connecting people like this together. So I just want to have a little quick, I guess, preface of how we want the evening to go. So we have a number of prepared questions for our panelists to answer to help with flowing the conversation from one topic to the next. But throughout the evening, we really encourage our panelists to pose questions to each other or expand upon anything another person has shared. We really want this to be a full discussion of these issues. And just to go over some general goals for the evening, we want to forward the conversation about and discuss ways to combat LGBTQ health disparities, discuss how we can improve SGM, sexual and gender minority health in medical education and training, and just connect this group of people together on this issue. And to the audience, to the attendees, feel free to pose additional questions to our panelists in the chat. I think you can chat it to everyone. And so we'll try and keep an eye on that as we go through the evening. It can either be to one specific panelist or to the group. And then we'll have dedicated Q&A time at the very end to open it up for any other questions. So before actually getting to the bulk of the evening, I think Thaddeus is going to lead us in a quick exercise about SGM terminology and getting us all on the same page. So Thaddeus.
Sure, thanks, Danielle. And so as you folks can probably already tell, I love to talk a lot. So I just use this space. No, I'm just kidding. What I'm going to do today, thanks to Danielle and Clark, is just level set us all, because we all might be approaching this space with different ideas of what does a sexual and gender minority mean and all the concepts. So we're going to do a very quick, like 3-minute exercise together. although I can't see anyone else except the panelists, I'm going to assume that everyone is doing it with us. So first, I'm going to ask you to stretch and raise your left hand. Hopefully all the JABSOM students are raising their correct hand. Okay, good. I'm going to assume that's happening. Now raise your right hand. Okay, and put it on your head. Right. And so your head is who you know yourself to be. This is your gender, right? So when we talk about gender and the concept of gender, this is how we know ourselves to be, right? So now take that hand and put it on your lap. And I know I can't see you doing it, but I'll know that your hand is on your lap and that's near your sex parts. So the idea of sex, when we talk about it in this context, is very far away from your gender, right? And usually people might conflate it, but in this particular context, especially, gender and sex are very different concepts, right? So your sex assigned at birth is not who you know yourself to be necessarily. So take your hand again and put it on your heart. And that's going to be your orientation, right? So who are you attracted to? Who do you feel romantic with, right? And again, your hand is very far when it's on your heart from your head and your lap. And a lot of times things are conflated, but again, your gender, your orientation, and your sex are all very different and distinct concepts. And finally, you're going to take both hands and just take your collar and just do this a little bit. And that's your gender expression, right? So this is how you express your gender in the world or how people perceive your gender in the world, right? So this is not only what you wear, but maybe how you talk, how you move, what you say, even just how you appear looking, just sitting there, right? So again, this is very different from who you perceive yourself to be, who you know yourself to be, to where you are, what you're assigned at birth and who you might love, right? So again, gender, sex, orientation, and expression, right? So thanks, Danielle, for that moment. This is just something we like to do with our community to kind of just have a really basic concept and level set together. So appreciate the time.
Appreciate you. Okay, so now we're actually going to kick off our questions, throwing it right back to you, Thaddeus, with telling us about the landscape of LGBTQ health disparities nationally, as well as here in Hawaii, from that public health perspective.
Great, and I'm not gonna go into a whole slide thing because I can show you folks like half an hour to an hour of slides. But basically, I think the important thing to know in terms of the public health perspective is that people who identify as sexual and gender minorities or LGBTQIA+, right, are more likely to have health disparities. And if we think about this, it makes sense. If we think about it maybe as a pathway, right? So if you are already being discriminated against, or if you are feeling unsafe with your medical provider, let's say, that means you're less likely to engage with medical providers. You're less likely to have support around health education, which means you might be less likely to get support in general, which means you are also more likely to be vulnerable to assault, bullying, all these things, right? And because of that, this community is also more likely to cope, like many of us do, with substance use or with other kind of ways, right? And because of that, that leads to more mental health issues, mental duress, suicidality, and all those other issues that come with it. So that's the general narrative. I'm not going to go into the direct numbers. Folks can always email me if they really want that. But just to acknowledge like that little seed, for a 6-year-old who might feel scared about being who they are, has implications way beyond along their life course. And I think probably Dee-Ann and Scott, as our providers today, probably see the implications of that moment that started very small and early, but how it kind of echoes across time for a lot of their patients. One other thing I'll note, and this happens in public health a lot, is we're very deficit focused. So I also wanted to acknowledge that a lot of our community members are amazingly strong and resilient. And the fact that they're still going and thriving today is a testament to how much they've already gone through. So as much as we might say 1 out of 3, local students are using marijuana, that means 2 out of 3 are not, right? So I think also important to remember that our communities are very strong, very resilient, and have developed their own ways of making sure that they stay healthy.
Okay, great. Thanks for sharing, Thaddeus. I feel like that was a good segue into our next question, which is actually for Cam. And we were going to ask actually about UH Manoa and the LGBTQ Center. And I guess we wanted to know a little bit more about what the center does and how it promotes health and well-being for LGBTQ students. And I guess how has the support of LGBTQ students changed and progressed over the years?
Sure, thank you, Clark. I guess to connect with what Thaddeus was talking about, was there's so many coping mechanisms that we might use in the LGBTQ plus community based on harassment and discrimination. It's the ongoing harassment and discrimination that leads to these public health concerns. And for me, in terms of making sure that our students can succeed, it's my responsibility to help eliminate harassment and discrimination at the university. So that was the first thing I just wanted to speak to. In order to have student success and in order to have health and well-being as a community, we have to get rid of the misgendering. We have to get rid of the not honoring of your chosen name. We have to respect you for all of who you are, all of your identities. And it's my role to make sure that that is addressed if that is not respected and honored. So some of the things I do is to make sure that we have friendly ways for me to interact with the students, whether it's a one-on-one drop-in space, but more likely a fun social group. One of the things that I'm really excited that we've initiated this past year is our Rainbow Hana program. And this is a peer mentorship program based on service and academic honors. So students are paired with other students in cohorts to form an extended family. And we support each other throughout the academic year and through the tough times, and to share strategies for dealing with those difficult situations. And then I'm able to work one-on-one in positive, healthy ways to deal with those stressful situations. So one of the things that I've seen change with the LGBTQ plus center is less intervention, less crisis management, and more prevention and more positive outreach. So I guess that's it in a nutshell. And please email me at lgbtq@hawaii.edu for any additional information. If you're a student out there, I look forward to working with you. It would be an honor. Thank you.
Thanks, Cam. Next, I'm going to ask Scott about your work. And I guess starting a little bit further back, how were LGBTQ health and health disparities discussed in your own education and training? And how would you have improved that?
Thanks, Danielle. Well, they weren't discussed. It wasn't discussed. It's not a thing. I think those of us who are in the medical profession who've gone through training and education in this capacity can recognize the fact that we didn't receive that kind of training. Studies have shown that over the course of a 4-year medical school program, plus an average family medicine, internal medicine 3-year residency, 7 years total, about 5 hours is actually spent on discussing these issues as it relates to LGBTQ people. So there's a lot of room for us to be able to expand upon that and figure out ways to better train our providers. It's one of the reasons why I was really passionate about trying to develop a program, an elective program for our Kaiser Permanente internal medicine residents. So I created an LGBTQ elective that they can take as one of their rotations through their residency program. And it's based on some of the work that I present over at JABSOM once a year. And I think it's that kind of thing that we need to start incorporating into other medical schools. There's, I think half of the medical schools and residency programs actually have something in place where they're starting to generate educational topics about this, but we have to start including this topic as part of the medical school curriculum, the PA school curriculum, the nurse practitioner school curriculum. We should be creating electives that these providers can partake in. And then I think we need to start incorporating LGBTQ people in their patient panels when they're actually doing their continuity clinics during their residency. I struggle to even be able to place LGBTQ or HIV positive patients or trans patients on the residence schedules, because it's all very restricted by their supervising, their attending physicians. We need to embolden health champions in the organizations, the healthcare organizations. We need to start talking about it and start bringing attention to it, because only then are we going to be able to start to close some of these disparities. But I do think there's a lot of room to do that, and I think this collective right here is a great way to start. And someone like you, Danielle, as you know, I just think you're awesome, and all the passion you've had for helping us with our program, and it's great to see all of you talking about this.
That was great, Scott. Wow, I really love that. And just as an aside, me and Scott actually worked on a quick elective together. It was a short session for first years, kind of working on seeing if they can get a little bit more awareness of different types of LGBTQ healthcare topics. And from what we saw, it was actually really helpful for them. So hopefully we'll see more in the future. And I also heard really great things about that elective for Kaiser. So really great stuff. And I think that's a good place for us to talk about what's happening with JABSOM curriculum. So Dr. Carpenter, this one is for you. How are LGBTQ health disparities currently covered in the JABSOM curriculum? And what are some future directions in LGBTQ healthcare education that you think JABSOM would be able to take on?
Thank you for the question. And I actually want to answer kind of what Scott's question first, because I think I was lucky. I think all we had back in my day of medical school training was 1 month of sexuality. And so we learned a little bit of what they thought was everything we needed at that time. And it really obviously was not enough. But I was actually one of the lucky people. And I say that because when I had one of my first patients who was in the hospital, and I'm just going to share this story, that when I got the chart and I was able to go into the room, and the chart had what looked to me like a male name. And I walked into the room and there was an obviously to me very female looking person. And I said, oh, I think I have the wrong room. And so I said, excuse me. And I stepped out and I went to the nurse's station and I said, oh, is this the right chart? And they're like, yeah, it is. And they're like, but you know what, don't call him by this name. She would rather like to be called. And she gave me, her name. And I said, oh, okay, that's fine. So I went back in the room and I was able to have a really fabulous conversation with this patient who shared many of just the tragic life stories, which I think is very common. Kicked out of her house at the age of 13 when she realized that, the father did not really understand what she was going through and how she's like, I'm a woman and I'm not a man. And I was born in, like you said, I was born in this body, but this is really who I am. And so in that discussion, we found some commonality. I played volleyball back in the day at Palama Settlement. Many of the people I played against were trans. Oh man, they were awesome. Anyway, and I'd play down at Waikiki, and it was and so we had that comfort level. So she was able to actually share a lot of information with me. And when I talked to my attending at the time and presented, this case of this person, and what was really great and what I really appreciated, and I think probably more practitioners need this learning, and probably Scott would agree with me, in just that there was no judgment. It was just, it is what it is, and this is who she is, and let's talk about what's going on. And she was getting hormone shots at the time, had not gotten all the surgeries yet that she had planned. But she was a smoker. So we talked about, hey, this is just like talking to a a woman who's on birth control in the same way that she's at an increased risk for DVT, you know, et cetera, et cetera. And so we went back in the room, and the way that the attending worked with me to discuss things with the patient made this to me, this is a normal person. This is a person who happens to have these issues that we dealt with. And so that was a great learning opportunity for me to, you know, just be a medical student at the time and really, you know, just kind of talk story and learn all about that kind of stuff. And that's something I hope that many people get, but they don't always do that, right? It's catch as catch can, you know, as it were. And so we actually just recently this year, given all of the things that have happened with the pandemic and whatnot, and whatnot, and of course all the increase in need for diversity, equity, inclusion. At the Johnny Burns School of Medicine, we've started a new thing called C-Code, and it stands for the Coordinating Committee on Opportunity, Diversity, and Equity. And in this C-Code, we try and look at diversity, finding those gaps, which we are now trying to address. Although truthfully, we've been trying to do some addressing of this over the last, I'd probably say, you know, probably more so in the last 5 to 10 years than in the previous decades, perhaps. And so working on these curricular needs, you know, for these students, but not just the students, but as I'm mentioning, also faculty, I think, and staff. And so there's a website that's being created, you know, putting global links on there, putting information on how to get some of that and how to share that. And then I actually had the opportunity to really work with so in medical school, in teaching, sorry, I like to talk a lot too, Thaddeus. Portuguese. So yeah, we would get along great. We work in small groups, and so our main curriculum is really problem-based learning, PBL. And so we take a healthcare problem, and we have that within the discussion groups of maybe 5 to 6 students, and you have a PBL tutor. And we give the PBL tutors some notes to discuss in case the students don't really bring things up. And so in each of our the preclinical first 2 years of medical school, which is basically more book learning and whatnot. I say books, but you know, obviously there's things online and audio and you know, in person, et cetera. But seeing patients a little bit, but not as much as in their clerkship, which is the 3rd and the 4th year. And so in those, at that time, what we have is we learn by organ systems, and within this, and we're using one health care problem to discuss a problem. So for example, it's a paper case or an electronic case, however, whichever way you're actually working in your group. And the first line would be, you know, this is a 17-year-old, you know, and you would say man or woman, or sometimes you won't say the gender, and it'll just talk about who comes in with a complaint of blah, 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 blah. And so in that discussion, we actually can put different groups together. We can discuss LGBT people in a way of, okay, this needs to be something that needs to be discussed within the group, within the learning of the small group. The students will then go back and figure out what's going on, bring back some information, share it with the group, but it's also up to the PBL tutor to kind of bring up something. Oh, these students just sort of glossed over this, and yo, hang on. Let's talk about this because that was not brought up as an issue, and so let's talk about it. And is there an issue? And so we just, you know, kind of throw it out there. Okay, so one of our cases in our first you know, group, the organ system is basically kind of a generalized one. So it's illness and learning about disease. And it has a gentleman who comes in, a 50-something-year-old man who has a husband, and so then that's brought up as an issue. Oh, okay, so is this a good thing, a bad thing? Well, they're married. You know, marriage actually has you live longer, so that's a good thing. Okay, so if this is a, you know, a man with a man, does that bring in other issues? And so that discussion is had within the group. And so we actually do this throughout all the different organ systems. And because our students are on the panel, I'm not going to give you specifics because some of them have not seen these cases yet. Sorry, Danielle, Clark has, but so So what happens is in each of these courses, the course directors look for specific cases that they can put in. And I can tell you in just reviewing all of this and working with the different course directors in each of actually every one of our entire 7 units within the first 2 years, there are multiple cases that bring up different forms of within the LGBT community. Although I do think that there probably are some gaps that we don't have that still needs to be discussed, and how can we discuss this? And perhaps there's a place where Clark is right now as a third-year medical student to bring up, how do you have those conversations? How can you ask these things? When it comes to the third year, there's not any specific formal training for specific LGBT issues that need to be addressed. But they do learn, how do you speak to a person? How do you get a history from somebody? How do you gain a sexual history, et cetera, et cetera. And that, that can be something that can be discussed later. So that might be some of the ways that we need to look at it. So one of our first passes is, what do we have now? So we have a few lectures. We have a panel where we have some patients who come in who the students can just ask a whole lot of questions, because it's like, wow, I haven't met anybody. Let's see what we can do. So those are some of the things we do. And I think some of the things we need to look at is bringing that information of what we know and what is going on to the C code, so that we can see if we can make some curricular changes, because as Scott said, there's only like 4 or 5 hours specifically brought up for LGBT community. And so do we need more, or is what we're doing now enough? So I've talked enough, but that gives you a little bit of information.
Thanks, Dr. Carpenter. Yeah, I think, like you mentioned, even though there is some coverage, there's obviously more that can be done, and particularly knowing that there's these really prevalent health disparities still in the world, in our state. And I really like the story you mentioned of the attending really showcasing how to be non-judgmental, good, competent, supportive provider, where I think a lot of physician mentors might not be as comfortable knowing how to navigate those spaces, unfortunately, which is what we're talking about, right? I wanted to pose another question to Thaddeus again, maybe speaking to what Dr. Carpenter was saying about, diversity and inclusion. We know that even though we use the term LGBTQ and SGM to be inclusive of lots of different members of this community, we know that it's heterogeneous, and particularly trans folks, gender minority, gender nonconforming folks face different sorts of health disparities and often increased levels of discrimination and violence in the current world. And I was wondering if you could speak to what those kinds of disparities look like, and if and how, I guess, DOH or what kind of initiatives are at play to address them.
Thanks, Danielle. That's a wonderfully giant question, and I'll take it.
Yeah, sorry about that. It was
no,
very
it's
long.
good. No, it's excellent. I mean, it's a really good point. I think you're speaking to probably the intersectionality of all the issues that we're talking about, and I think that many of our panelists already alluded to. But really, the basic answer to your question, of course, is that when we talk about sexual and gender minority communities or LGBTQIA+ communities, they're not a monolith, right? Already there's so many letters. So that we're very diverse. We come from different experiences. We come from our own kind of stories and journeys that are not always the same as everyone else's. And definitely there are commonalities that we all experience, but I don't think we can always assume that's going to be the same for everyone. So, so when we think about that, I think we do have to consider all those other layers of identity that could affect someone's health. So I think, especially when we think about race, or we think about indigeneity or poverty, houselessness, all these issues that affect many of our patients and our loved ones in Hawaii, especially, these are all pieces that we have to consider, as well as their sexual and gender identity. And I think we have to kind of consider how that plays out, right? I mean, I'll just note, shout out to the cool Hana project right now, because they're going to put on the Transgender Day of Remembrance on Saturday. I'll put the link in the chat for everyone. But that event is every year, and it commemorates and honors those who have passed, who identify as trans or gender nonconforming. And unfortunately, in the US this year, we have the highest number of trans people who died of violent deaths. So primarily trans women and primarily trans women of color. So we can't only look at sexual and gender minority as the only piece of someone's identity. We have to look at all these other pieces because they all play together or interplay together. And then I'll just end really quickly with a quote that I always thought was beautiful. And I forget who said it, but it's basically, they said, when you pull up a plant, you find it connected to the rest of the world. And I think that's what we have to really consider is we can't, everything is related to everything else. So when we're doing this work for sexual and gender minority people, we're doing all of that work around racism, indigeneity, housing, poverty, all of that.
Wow, I really love that analogy that you just gave. And I think that brings us to our next question, which I also know is a biggie, but I think that's an important one for us to transition to the second half of the night, which is about LGBTQ patient care. So this one's a good transition question for anyone who's willing to take it. In the sense of time, maybe we'll try and keep it down to maybe like 2 minutes though. And it is, what are the ways that healthcare professionals can paradoxically perpetuate or exacerbate negative healthcare outcomes for LGBTQ individuals?
I can start to take that one. I mean, 2 words: implicit bias. That unconscious thing that all of us do in our communication and our behavior and how we interact with people based on things that we didn't even really have any control over, how we were raised, the cultures we were in. I think that feeds into everything that we do all the time. And it's really important, particularly as healthcare providers, that we recognize what our implicit biases are. And it's a really, really challenging thing to do because it's kind of like uncovering something you don't even know is covered. But I think it comes out in little ways. I like to give a good example of a microaggression that a patient shared with me, a patient of mine who was living with HIV, who went to the pharmacy to pick up their antiretroviral medication, and just standing at the cashier, and in that moment of the cashier looking at the medication, knowing what it's for, and then just looking up at the patient, and it's just that extra glance, just that extra little look, and that's it. It was just that little microaggression that probably she had no intention, no bad intention, but unfortunately for that individual, that is perceived as something that's stigmatizing. And we have to be really mindful of how we're behaving, how we're communicating. It's only when we start to do that we can start to minimize some of these microaggressions. Oftentimes it's just a staff member who is just trying to say the right thing and do the right thing and just says the wrong thing, and that's fine, it happens, but we have to find ways to correct that and figure out how to understand that these individuals bring a sense of minority stress into the environment. And it could be just a very, very small thing that triggers back that stress and that stigma. So I think it begins there.
Yeah, I think that's definitely it. Those pieces of, especially when the nature of healthcare is so altruistic, it's easy to remember that there are ways that we don't realize, or even worse, ways that people intend to perpetuate these negative biases and practices. Thaddeus, did you have something to say?
Yeah, I think there was a beautiful point by Scott, and I just wanted to note something that's we learned doing this work in the community is just allow yourself to be uncomfortable. So I think a lot of the times we're trying so hard to help people, and it really is painful to hear that we're hurting people. But allow yourself to acknowledge that and just be like, I hurt someone. and I'm uncomfortable, and my minor discomfort is probably not even equal to what they experience over a lifetime of discomfort. So if you can sit in that discomfort a little bit, I think you can learn from it and you can become a better person and better provider.
If you're not uncomfortable, something's probably wrong.
Good to know. I live in a state of discomfort and anxiety. Just kidding, just kidding, just kidding. Okay, so this next question is pretty general, and maybe I'll throw it to Cam on what components of medical training we think are essential for what we've been talking about, training inclusive, compassionate healthcare workers, and maybe speaking to how, you know, we just teach everyone to be respectful and knowledgeable about LGBTQ issues, you know, at the undergraduate level or, you know, in the community.
To start to answer this question, I see a question that popped up in the chat and Q&A. So I just wanted to use that as an example of something that we talk about at UH, whether it's a safe zone training or a talk I might be giving to the School of Nursing or a JABSOM about the importance of honoring pronouns. And thank you to the person who asked the question about what's a good way to ask someone their pronouns and to collect that information when I'm meeting with them in an intake, for example. I love how we introduced ourselves and shared our pronouns. I say just flat out, you can't tell what someone's gender is by looking at them. And it is not a good practice to only ask people their pronouns if you think they might be mahu or transgender. Wrong, 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 wrong. That gets into the offensive territory. So that's why I love what we were doing in the beginning, where we all shared our pronouns. So for me, whenever I meet someone for the first time, or whenever I start a presentation, I say, hey, nice to meet you. My name's Cam. My pronouns are he, him. The name I go by is Cam. Is there a name you go by? I'd be happy to know your pronouns and honor them. So that's one way to start the conversation. And one way I just like to standardize it in terms of any way of getting to know each other, and then to get into the reason of why we're there for that day. Whether it's finding out how to drop a class or how to get the medical intervention that's needed for that day. So thank you to the person who asked that question. I'm not sure, Danielle, if I'm going down the right path in terms of the kind of information that we're looking for to address medical needs, to address health and well-being. But for me, one of the central things is to be able to affirm the whole individual and as they come into that space. And that's the necessary component to get the conversation started so that the care can be taken to address the concerns of why they're there that day. And one of the reasons that's also so important is there's a lot of anxiety that often comes with coming into getting healthcare. I was talking with some first-year nursing students the other day, and I just have to share, my heart was excited in talking with them and seeing the future of the nursing profession with their interaction and ideas and joy for caring for our LGBTQ+ communities. And knowing that there's so many different strategies for being affirming and allowing everyone to bring their whole selves into the waiting room, they're talking about how they really want to go into nursing because they want to make sure people are comfortable in the experience. And I think that's something that we could also think of as medical or caring or healing professionals. What kind of tone do we want to set so the person could really get better? Because I think it's just so much, well, not from a medical perspective, but it's just so much harder, I think, to heal when I'm not feeling emotionally fit. And if I was harassed or traumatized or stimulated in some sort of way when I was seeking help, that's not a good way to start the process. And it often ends the dialogue and the healing experience altogether. So that gets me to the kinds of conversations I'm excited about having in curricular changes or in addressing health and caring for our communities. Anyone else want to add to the example and the question that was put in the chat? Go for it, please.
I just wanted to mention at different clinics, since that sometimes it's hard for people to actually speak up because they would feel stigmatized. And sometimes it's a little easier to write things down. And so there's always these intake forms. And so I'm thinking that in these forms, I know we've been trying to, in different places that I've worked, trying to be more inclusive. And I'm sure Scott probably has a great form that he can maybe share with us from Kaiser, because they're always, doing great things. But
As long as you can help me with that website.
I can do, but that's something that I think can be added very simply, and to not actually only have a male female category, or you know what I mean. So so look at your patient as a whole, and what would be the right terms that we can use, and have those discussions, and understanding that you are also trying to be inclusive yourself, and acknowledging that I don't know everything. I need your help in explaining to me what you mean by I need to be treated this way, because I want to treat you that way, but you have to share with me what that way is. So.
I think that's so well said. So well said. I totally agree with that. And in CAM, I too agree. I think it's about, I tell the medical residents when they rotate, I tell them you can order labs, you can diagnose, you can order studies, you can treat, you can do all those fancy, beautiful things that you can do with your degree. But if you cannot establish that relationship and that trust and that confidence, and allow an atmosphere and an environment that is totally transparent, you lose it. You lose it all. None of it matters after that. For me, I just cherish the stories. I listen to the stories. The stories inform everything. And sometimes in my first consultation, I'm in that room for an hour with a trans patient, and I'll realize, oh my God, you've never ever told anyone that. And it's profound to me, and that's why I love what I do, because if I can help just that little bit to open them up, to allow them to come just a little bit closer to their most authentic self, then I've done my job. And then go get the labs. So yeah, it's about that relationship for me as a provider.
I'm just going to add to I feel like what's so powerful that Scott and Dee-Ann were kind of alluding to is that so many people from our community have felt so hurt or stigmatized by their interaction with healthcare providers that it's surprising sometimes to them when someone is nice to them or understands them or calls them by their name. So I just really thank you, Scott, for providing that space for those patients, because that likely could be the first time that they've ever felt safe enough to share. So just really want to honor our providers for just providing these spaces where people can feel safe.
Okay, so I think that this was a lot of great discussion. I loved a bunch of the points that were brought up. And it actually kind of makes me want to share a quick story. I told Daniel that I might do this, so I'm kind of excited to say it. But I really do think that it's important to kind of normalize these conversations and be, I guess, sensitive about how you approach things, because we don't know if this is going to be the first time that someone ever shares these things with you. So a story that sticks with me was when I was a very little kid and I was still in Catholic school. And I remember being told being gay is something that isn't looked upon very well. It's kind of a sin, really. And so I went to confession multiple times throughout the many years that I was in Catholic school. And I was like, I like guys. And this is something I need to repent for. And the priest who I was confessing this to although he didn't say anything like, okay, well, that's something that's bad, he never said anything like, well, that's okay either. He would just tell me like, okay, well, why don't you go pray on that? And that kind of informed me like, okay, well, maybe it's not bad. He didn't say it's bad, but he didn't say it's good and it's not normal. And those are very tiny little things that I think can plant seeds of stress and trauma that we're talking about and is a focus of tonight. So thank you guys for sharing. And I think that this brings us to the next part, which I think we will also have lots of things to share about, which is what are your best practices on the initial evaluation of an LGBTQ patient, and how would you approach like sensitive topics on sex and gender?
This question too.
Is it to all of us?
Yes, I meant to say yes, very generally. It sounded like everyone was having a great talk, so I figured a general audience thing would be great.
I'll just start with a simple one then when you're talking about engaging. So, and Deanna mentioned this already, but like intake forms, right? There's a very simple way of just asking 3 questions. One is, you know, what orientation do you identify as? What was your assigned sex at birth? And what is your gender identity? So you don't have to be like, are you transgender? Are you this? You're just asking 3 basic demographic questions. And if you put them in the demographic section, you know, it's just a normal question that everyone gets asked. So I think adding those 2 questions to an intake form is a very simple way of showing that it's normal and that it's asked of everyone.
I also want to I just saw in the chat that someone says that we need more providers from the community. And I think what happens is people find out which providers can give that trust, whether they're from the community or not, and the word goes out. And that's when you get patients who say, I know I can trust you and I can tell you this. And so I feel like I can do that. But I also feel like a step forward that we need to do is really provide education to those providers out there who don't know what pronouns are, who don't understand that you need to change your intake forms, that there is a term called non-binary. I had a fun time explaining that to my parents last night who are in their 80s. So it was a really interesting conversation, and I could probably use that as a go-to on how to teach others. I mean, and that's really important. But I think that's one of the things that I've seen. I've had patients come to see me and say, hey, I heard that I can actually talk to you. So, you know, and they share things that they haven't shared with anyone. And like Scott says, it's those stories, it's that kuka, that talk story that I live for. Like, this is why I became a physician. This is awesome. And if I can just help you in one way, just move forward to better yourself, whatever that means for you. You know, I have my own agenda, terrible, yeah, doctors, but I need to listen to your agenda because we have to find that compromise, because if I don't hear you, you may not necessarily hear me, and how can I be there to help you?
Yeah, that's really well said. I would add to that, you know, what the question posing, you know, what's your approach in sensitive topics and how you talk about these things? I think that all comes very easy after, I mean, once you've created that kind of environment, that patient-centered home, and you've developed that relationship, and it's trusting, and they're speaking to you and they're talking to you, and the rest of it just comes out. I mean, I find that most of my patients who I have a relationship with just have no problem coming and telling me, hey, I really need my, STD test done, and just will kind of give me the whole history of the last 24 hours, why that it might be. And I appreciate that, because I can't take care of them unless they're honest with me and transparent. But it really does start with that type of relationship. And I would also add, I think that's where it gets really tricky is because, like you're saying, Dee-Ann, if, because I'm that provider too, that when they come and they're in my clinic and they say, I'm told I wanted to get Kaiser so I could talk to you. And as much as I, of course, love that, it just breaks my heart. I can't do it for everyone. But also when you realize that you're just a couple of them out there, you really get a sense that there's a lot of stigma out there. Because when it all rolls down to just one or two, something's wrong. And I it's why we have this conversation.
Thank you all for sharing. I couldn't agree more. And I think that piece about how to increase representation of LGBTQ folks in the healthcare workforce is major. And just like all the other things we've talked about tonight, does not have an easy one-off answer. But I'm curious, for anyone who would like to answer, how do you think that we can, have these strategies to increase representation of LGBTQ folks and, particularly transgender minority folks in the healthcare workforce? And I see a question in the chat that goes right along with this. This is just from Dr. Schiff. So to the comment about needing more providers, how do we find potential students from this community without asking applicants to self-identify as being from this community? So.
That makes me think of something I'm longing to see reawaken at JABSOM and in our community, is to have a group for students who are LGBTQ plus and ally within JABSOM, and to have a professional network association here in Hawaii that could mentor them, and to have the back and forth communication, nurturing, mentoring, professional development that can serve as the conduit for the future medical providers and care providers in Hawaii. So that's something I'm really excited to see flourish. I think the people are here to make that happen. And if anything could rise out of tonight, I would love for that to happen. And please email me if you'd like to join that conversation.
Yeah, I didn't know if Danielle was going to unmute, but actually, sorry, Clark, I didn't get a chance to talk to you the other day. Otherwise, we would have been in the same conversation. But Danielle and I were actually just talking about that exact thing, Cameron. When there was a study done a few years ago looking at what more can we do or what was already being done. And that was sort of some of the impetus as to why some of the cases had changed, because there really wasn't any, and we need to talk about this more and bring this up. But within that conversation was also asking the students, how many of you identify as whatever the different terms were? And when you look at them, they were not all straight. So there are students that actually are in medical school that are not out. What does that mean? Does that mean that there is also still a barrier, that there's still a stigma? So I'm here to tell you that we will start bringing that forward again at JABSOM, and we will have that conversation. And Cameron, you'll definitely be part of that. So mahalo for those of you, because this conversation needs to be continued, and this is just just the beginning of it. I know you've had conversations prior, but we will be there to do that more.
Okay, thank you both for that great information. Hopefully we'll see something soon with JABSOM. I think that this is a really great move forward with the discussion tonight. So really looking forward to it. This next question is actually for Thaddeus, and this is in regards to harm reduction. So we were just wondering how you recommend we incorporate it into everyday and public health practice.
Sure. So as folks may have heard, although I talk really fast and voluminously, just like the lashes, I am part of the harm reduction services branch, which encompasses HIV, hepatitis, and STIs, and also currently medical cannabis. But harm reduction is basically, I think, a very like duh kind of philosophy, which is that you treat people non-judgmentally, you celebrate positive increments of success, and you meet people where they're at, right? So, and this is really exemplified in the syringe exchange that came out of Europe in response to the HIV epidemic, right? So people who are injecting drugs were realizing they're not getting a lot of support, the attention is not on them, so they're like, let's take care of our own communities. Even if you will continue to use drugs, we're going to provide clean needles so you don't get HIV and so you don't spread HIV to other people as well. So it's really about community knowing and empowering community to kind of to address what they need, right? I also note like harm reduction is stuff like seatbelts, right? Seatbelts will help reduce the harm, or this is a great example, but like, you know, like pen caps, there's a hole in it, in that little, the tip, it's in case you swallow it, since you're chewing on your pen, you can still breathe and you won't choke, right? That was made specifically so people don't choke on pen caps. So all these things that we have in our lives are just ways of reducing the harm and also acknowledging that people make choices that are typically not healthy, right? Like I might be stressed today, so I might go smoke. I might go after this and get 3 Big Macs because I'm really, really hungry. Or I might ride on a bike without a helmet. These are all things I know are not the best health options, but for me, there is a value to it. And I think like what we've all been saying, if we can talk story with people and understand the values and the priorities in their lives, we're practicing harm reduction. We're helping them make choices that are beneficial to them while reducing the harm. So I hope that was helpful as I gave you everything.
100%. I also just want to remind everyone, you know, to continually put your Q&A questions in the chat or the Q&A feature. I don't really know how that works, but I see them. So feel free to keep putting them in there as we're going to wrap up at 8:15, so I got a little bit more time. So I think there was a question that came in specifically for Scott about opportunities to work with the LGBTQ community as a PA, but I wonder if we could even open that up to, you know, everyone on the panel of how to, I guess, get more engaged with LGBTQ community if you are, you know, interested and passionate about this topic.
Well, I think in a, you know, interested specifically in a healthcare application type of way, I would recommend mentoring and reaching out to me. I would be happy to mentor. I would be happy to precept. I would be happy to share knowledge and experience. And we take students, we take PA students, we take pre-PA students, we take pre-med students, med students, you name it, over here at Kaiser. And just be great to be able to expose you to the world of all of it. You know, my clinic, it's located at the hospital, and we take care of all the people living with HIV and all our PrEP patients, and then all of our gender health patients who are undergoing either social or legal or medical transition. So we'd be happy to be able to broaden your horizon and introduce you to a lot of the work that we do. I'm actually working with one of our internal medicine residents right now who did the elective with me, and he's really been engaged with a lot of the work we're doing and has a lot of ideas to bring to it. And we're starting to get a lot more research involved. I think the goal for our clinic is to make it a center of excellence here in Hawaii, to be able to provide that kind of gender health and gender affirming care for our populations here. So please feel free to reach out to me, and in whatever way that is, please come.
Okay, that was great. Yes, again, I've heard so many great things about your program, and I'm excited to see more things from it. And, you know, hopefully I'll find some time to come over and learn a little bit from you. But We have one last question, I think, and then we might open it up to the floor for more questions. And this one is addressed to everyone. Let's try to keep the questions a little bit short since we have about 10 minutes left or so. But we were just wondering what you guys wished every healthcare professional knew about caring for LGBTQ patients. And feel free to share any experiences that you guys had or any best tips.
I'm not going to talk again. I would say, you know, although we speak of LGBTQ as a group, as a population, we don't want to ever forget that these are individuals within the population. So at the end of the day, we want to take care of someone and have a partnership and a relationship, a provider-patient relationship that's based on that individualism. And so as much as we do want to speak of the greater whole, because that's the disparity of the population, you know, these are individuals too who have very individual, unique needs and concerns.
Thanks.
Oh, sorry. Yeah, I totally agree. I just wanted to also just say, just creating that safe space and allowing for the conversation to be had. Trying not to make assumptions. I think we all do. I'm speaking for myself. And when you make assumptions, then there's an issue with that. So you know, and you are perpetuating stereotypes. So I think to be okay with asking questions. So as a provider, I'm not going to know everything. I know that's unusual for you to hear, but I don't. And so please be okay with us asking questions so that we can be there to learn from you on how to care for you. But I do think that we need to create that space for that conversation to be had. And that's super important. So that patient-provider relationship is the relationship in order to develop that trust. And without that trust, that's not a relationship, right? So I think that's the most important thing, to be there, and it's your integrity, your care for people as people.
Thank you. I want to open it up for anyone who would want to ask any more. I see that someone has their hand up in the participants, but I'm not sure if attendees can unmute or if you would want to chat anything in the chat. That's always open. There's a lighter in the meantime. There's a lighter question in the chat from someone, which is, do you guys have any favorite LGBTQ media or music that you'd like to share or recommend? We could do maybe like one thing each. I don't know.
I can answer that right away. It's called On Earth We're Briefly Gorgeous by Ocean Vuong. He's a queer Vietnamese poet, and it's probably one of the most beautiful books I've ever read. And a perfect bookend, it came the same year, is In the Dream House by Carmen Maria Machado, and it's a beautiful book as well. So those bookended 2019 for me, and they're just magnificent.
I just want to mention a series on HBO Max, We're Here. And it has some drag performers from RuPaul's Drag Race, Shangela and Bob the Drag Queen. And their November 22nd episode is going to be in Kona. So some of you will know the people who are featured in the episode. It's a show where they go to small towns around the US and now in Hawaii to bring some fun and some drag to different parts of the world. So check it out.
Okay, I think we're gonna have our, I guess, final question before we wrap up for the evening. There's also in the chat a question about gender neutral alternatives to Mr. and Mrs. I'm not sure if we're gonna be able to get to that. But in either case, I guess I want to reiterate the goals that we had for this evening in the last final 5 minutes, which was to forward this conversation on health disparities, discuss ways that we can improve medical education, starting with JABSOM and beyond, and then connecting folks who really care about this issue. So maybe we can go around a quick, 1 or 2 key take-home points that our panelists could have for anyone who's in the audience, maybe thinking about going into healthcare, currently working in healthcare. I'm sure there's a number of medical students on the call. So yeah, final key takeaway points from everyone. And I'll start. Okay.
I was just going to say, all I would add is, it's this, going back to this idea of bias. It's literally everywhere, and if you are sensing it, it's probably happening. And people need to speak up. You know what I mean? We need to kind of hold each other accountable. And I think that is relevant in any environment, whether it's healthcare or whatever it is. We need to speak up. We need to hold each other accountable. And it's just, similarly to just not being a racist, we need to be an anti-racist, but we also, we need to be anti-homophobic. And we have to speak up, and we have to be active about these things, because only when we do start to talk about it and normalize it and validate it and stop the others from their microaggressions are we going to be able to move forward in a healthy way. And that's my soapbox.
I guess I would just simply add to, I know you've already been for decades very patient with the healthcare community, but perhaps realizing that it's because we need to be educated. And so to help us to be educated, please be there and be able to speak up, as Scott says, and share things. And I think we will also try on our side to certainly educate our students who are our future providers, but certainly also we are here to provide for you as our patients, and so to help us to be there for you to trust and have that two-way conversation, and not just a one-way conversation. So I think that's super important. So I think that's the biggest thing. And I would hope that for people who perhaps are not part of the LGBT community, to be an ally for everyone is the next best thing, so that we can help everyone. So mahalo.
I just want to speak briefly to the LGBTQ plus folks here tonight, and to encourage you to continue to advocate for your well-being and know that it's okay to care for yourself and each other. And part of that is having that two-way conversation that Dee-Ann's talking about. And know, please, that if you do need a barrier, please don't stop seeking the help you deserve. Let your friends know, write a letter, let the agency know, the clinic know, but please get the support you deserve.
I guess I'll end with it. My last takeaway is just, to recall and remember you as individuals and community members that we all have power, and not to give up your power willingly or facetiously, and to really draw on the strength of your community, as Camaron was alluding to already. So I think maybe that's the last takeaway, is to remind ourselves that we do have resiliency and strength. So thanks everyone for joining us tonight.
Okay, great. Thank you so much, everyone, for coming. I just wanted to give a quick shout out to everyone, the panelists, the Hawaii LGBTQ Legacy Foundation, the faculty advisors that helped set this up, the PHJ Symposium organizers, and of course, Danielle and Saskia for helping out. Thank you. Everyone have a good evening.
Mahalo everyone for tuning in today. Right before everyone leaves, I just want to kind of give a quick story about Danielle and mahalo her for putting this event together. So Rainbow Town Halls is truly a community grassroots event that the Legacy Foundation is really trying to kind of expand how we view pride. And Danielle literally just emailed a board member and said, I want to also do a Rainbow Town Hall. And I think because of her efforts, we've had great conversations today. And so mahalo, Danielle. And honestly, the goal of the Legacy Foundation is to really just gather threads from individuals, gather threads from organizations, and kind of weave them together. Because I think individually, there are so many of us doing great work. And my hope is that through these conversations, we can connect people so that we can do great work together. And so if you are interested in having a Rainbow Town Hall geared towards an issue that you'd like to address, please, honestly, contact us. We'd love to see it and make it happen. I know we're planning a Rainbow Town Hall on mental health. And I would love for us to continue this discussion because health and physical health are so interconnected. So again, mahalo, Danielle, mahalo for everyone for attending. And thank you to the panelists for really sharing your mana'o and your stories. And Clark for being a great co-moderator. I know it must be nerve-wracking being a student and moderating these amazing individuals, but you two did such a fantastic job. So mahalo to everyone, and thank you again, and I hope you join us in future Rainbow Town Halls.
Hello, everyone. Have a good night.
Thank you. Have a good night.
Thank you. Good night.